Lovely. Oh, thank you very much, and thanks so much for letting me speak among such amazing sort of speakers already. It's been really, really interesting. So thank you so much for that. So yes, my name's James Jones. I'm a clinical nurse specialist at Robert Jones Agnes Hunt, which is a hospital in Shropshire, which is in England, which is sort of in the middle of the country, really, sort of on the border next to Wales. I'm just going to quickly tell you a tiny bit about our service, and then I'm just going to talk briefly about some of the ways in which we support our patients on their journey, and just some of the bits of paperwork we use and how we can sort of interact and sort of educate some of our patients and families. So Robert Jones Agnes Hunt, it's an orthopaedic hospital, and within that sits our neuromuscular service, and we have a caseload of about 1,300 patients, ranging from birth to old age. We're a seamless service, we're an MDT service, and so we're lucky enough to sort of transition from children's to adults, and we keep our patients. We're about 600 children's and 60 Duchenne muscular dystrophies. We cover area North Mid Wales, Cheshire and West Midlands, so demographically it's a very, very big area. And we provide a diagnostic service and long-term management to a wide range of inherited neuromuscular conditions. We're a hub and spoke management, and we coordinate effectively. We sort of are the gatekeepers, and then we outreach to primary, secondary and other specialty healthcares and education settings. We have 2 consultants, we have a psychologist, we have 2 full-time specialist nurses, we have a care advisor, we have 3 physiotherapists, and we also have some DMD hub sort of research posts, which are physiotherapists. We also, off the back of our visits, have managed to sort of apply and get time for an OT, which is hopefully going to join us soon. So we're really excited about that. And we provide care in a variety of settings, including the hospital, home, hospice, and at school. And we also do special educational teaching at conferences. So the start of the journey really is from being diagnosed, and obviously they're seen in clinic at that point in time. And we developed a patient passport, which we give to all our new families. And this is a document, it's an 8-page booklet, and it kind of sort of is something that the families can keep with them all the time. It talks about other professionals and contact numbers for important people that you might need to be in contact with. It discusses open access and gives you details on how to access that. It touches on transition. It gives information on hospital admissions and also able for families to record that information. So when they come back to clinic, they're able to share that with us. It looks at clinical trials, and it also has some sort of areas where they can ask some questions and they can write down their own personal information and make it more about them, really. And really, once they've had the initial diagnosis, and obviously it's really difficult in the first sort of meeting, we often follow up with a phone call, and then we go and do a home visit. And normally we've given this professional's book out at the start, but a lot of the other information we take out to the home, and we sort of judge when the information is ready to be given, and so we can from that make a decision on what's best and what's suited to the families. We can also meet the rest of the family, and we can also get an understanding of how people are living and how we can support in the best way. We also follow on from that, and we go into nursery or school, and we give a general overview to the teachers and support staff about the condition and about what to expect and about how they can support in the school or educational setting. And we also go and do teaching sessions to, when age appropriate, to class members. And that can be usually at the discretion of the child when they're ready. And we go and do entertaining sort of follow-ups on that. And that's really interesting. And that allows everyone to sort of be involved in the journey and just sort of have an understanding about the condition and the severity of it. We also then do another visit around about sort of 8 or 9, and that's to look at adaptions and equipment. And we've done an initial one at the start, but just with OTs and with care advisors, and we'll go back out just to engage the local community and look at things that we can use moving forward. So that's at the start. I picked a couple of sort of points that I thought are interesting because we do have a lot of paperwork, and I know a lot of centres are doing great work in different ways as well, but just this is the way we do it. So regards to the adrenal training, so once they're started on their steroids treatment, we will then order the medications, and that will be sent out to the home. And again, we'll go out to the home again, and we'll take all our equipment out, and we have injection pads, and we have sort of training tools that we can use to sort of help with the family in terms of learning how to use these medications, because they can be quite tricky. And when you've got so much going on and you're managing everything else, it's just another layer of something that we felt that being in the home environment can just give them a bit more time away from other distractions where we can learn all about this. We also provide lots of ongoing training and online apps. Honestly, we've got a great app for administering the hydrocortisone, and we use that as well in conjunction with the teaching. And we also go back into schools to teach the school teachers and first aiders that are there, because obviously quite often they're taking these medicines into school with them. So we felt it was really important that not only should we be teaching families, but we should be also teaching educational settings, because potentially that's where they might be. This is the bus bed adrenal information sheet that we give out, and we're able to look at sick day dosing, but we're also able to put their details down, talk about steroid regimes and sick day dosing, and also if they are admitted into hospital. It just gives, because we cover such a large area, and we've got lots of district general hospitals who sometimes have no understanding of this. It gives them a base of where to go, and also contact numbers to be able to contact us and let us know what's going on. Then moving on to look at transition. It's another time we sort of become heavily involved, and we use a document that's part of the NHS called Ready, Steady, Go. It's designed to support young people transitioning from paediatric to adult healthcare services, and it empowers them to manage their health independently. It's 3 Ready, Steady, Go. So it's 3 documents, and when we looked at this, we decided that we'd offer all our patients each one from 12, 14 and 16. So ready at 12, 14, and then go for 16. And we have a transition nurse who we also hold clinics with our adult team as well. They're lucky enough that they stay with our team in terms of neuromuscular, but obviously they move through transition in lots of other ways, cardiac, respiratory, and everything else that comes with adult services. So the Ready document is initial phase, which focuses on raising the awareness about the young person's health condition and the importance of medical care. It also encourages them to start thinking about their future healthcare needs. And it's a really nice document that stimulates conversation and allows us to understand where they are, what's important to them, and how we can support that, facilitate that. The Steady document, in this phase, the participants delve deeper into managing their health, and they learn about their medications and recognise the symptoms and understand when and how to seek help. And then finally, the Green stage, which is the final phase, which prepares young people for the actual transition to adult services. This includes practical advice on navigating the adult healthcare system, understanding legal rights, and ensuring they have support in place. And we work really closely, and again, our transition lead really helps us with that in terms of navigating between the adult world, because obviously it's vastly different from when they've been in children's services. The benefits of this programme, it's really empowering. So the programme equips young people with the knowledge and skills needed to take ownership of their own healthcare. They learn to communicate effectively with healthcare professionals and make informed decisions about their treatments. The preparation, by gradually introducing the concepts of adult healthcare, the programme helps reduce anxiety associated with transition, and young people can become more familiar with what to expect. And hopefully that makes the process smoother. And then improved outcomes. Research has indicated that effective transition programs like Ready, Steady, Go can lead to better long-term health outcomes for young people, reducing morbidity and mortality associated with poorly managed transitions. The implementation, it's implemented in various healthcare settings, including hospitals and clinics. And what's really nice about the document is it can be moved. It's a movable document that can be taken anywhere really, and lots of people can tap into it. It's designed to be flexible, adapting to the individual needs of each young person. And resources are available in multi-languages and formats to ensure accessibility to all participants. And again, in this time, we're often doing, again, more home visits and lots of sort of availability to speak, whether that is on Teams as they become teenagers and they don't want to engage so much. We offer a very different style of formats in which we can engage with our young people to try and sort of give them the best. And then finally, we look at our emergency care planning. And then again, that's another thing that we found difficult over time, is having, understanding the timings of conversations, having the confidence of clinicians to initiate discussion, worry about upsetting people, being productive and giving the power to the young person for, and not wanting to upset them. understanding cognition and capacity issues, having a conflict of preferred wishes. And so we felt that, as well as having an advanced care plan, we would introduce an emergency care plan, and really something that we felt was really important for people to keep with them, that they were able to take to hospitals if they were poorly or became unwell, but weren't sort of at the end stages and needed a voice and needed some contact details and the priority of being able to be listened to, but also be able to get us to be contacted so we can support them. And they're really, really good. We initiate emergency care plans, and we do this in acute settings, and then we revisit every 12 months, and that allows us to sort of respond to physical changes and provide opportunities for re-evaluating. It gives us an opportunity to discuss fears and wishes, which can be empowering and promote self-determination. We've had some really good feedback from this, and what we generally tend to do, I think yesterday Professor Derek Willis had spoken about our traffic light system, and that's something that we sort of note down, and we look at our traffic light system, and when we feel it's appropriate, we sort of initiate these conversations and get something in place. This is what our advanced care plan looks like, or emergency care plan, and it has all the contact details, it has all the specialist knowledge that needs to be on there, but also gives some tick boxes that allow some conversation, and then that's signed by them at the end of, and then hopefully that document can be used. We also hope to move forward with this and develop something more on top of this, in conjunction with hospices as well. And part of what we do is with our adult hospices is something called a symptom control management, and that's where, when they leave children's services and then we go into adult services, we've started developing symptom control clinics, where they can tap into adult services, because adult services and hospices are very, very different, and they're not done in the same vein as children's hospices, but it allows them to be engaged with adult hospices, be known to adult hospices, and also manage their symptoms, which all ties into this as well. So thank you. That was a very quick sort of insight into some of the things we do and some of the ways we work, in terms of sort of educating our patients, and I hope that's helpful.